Okay, in this next video, we're going to go through a case, a simple case that's going to show how that framework that we went over in the first video, use an example to show how it works. Okay? Okay, so now we're going to go through a quick case to demonstrate that process we talked about in the first video. And so we have a patient here who comes in saying that his chest hurts. And so your job is to go from the patient's symptoms to a diagnosis and ultimately treatment. And so this is the graphic that we showed in the prior video that had really basically 4 steps that we're going to go over again and again and again. And it's going to be acquiring data, interpreting and organizing that data, making hypotheses, what we call a differential diagnosis, and then testing that differential diagnosis. Right? The differential diagnosis is a guess of what things could possibly explain the patient's symptoms, what diseases. And we're going to go through that using first just the initial data we have, then the history, then the physical, and then the diagnostic testing that we get. So let's start. Okay, so the first step is you can see this, the 4 steps are listed here across the top, and we're going to acquire the initial data. And the initial data we know is that the patient was saying that his chest hurts. We know that he's talking as well, and that he has no signs of trauma, like he doesn't have a knife sticking out of his chest, right? So we're going to interpret that information now. We're going to say it's chest pain, that he's conscious and he's atraumatic. And we start making a differential diagnosis, like what kind of things could be causing chest pain. And so you might think, well, heart attack can, pneumonia can, heartburn, and a stab wound. Okay? And then you're going to test their hypotheses. And remember, all the hypotheses are going to be tested by assigning them probabilities. And we have numbers that we can assign, but you know what? It's hard to assign an exact number, so we maybe even can say very unlikely, unlikely, uncertain, likely, and very likely. And these are the percentages that correspond to that. So for these ones that we have, a heart attack, we don't really have any evidence here that makes us say that it's very likely or very unlikely. So we're going to say that we're uncertain about it, and we need to do some more data gathering. We need to test it further. For pneumonia, same thing. We don't really have any data there that helps us say that it's very likely or very unlikely, so we're uncertain and we're going to test it. Same thing with heartburn. Now, stab wound, we said there are no signs of trauma that we can see, but maybe we're unsure. We only see the front of the patient. We don't know if there's something, a stab wound in the back, or we should ask him if he's been stabbed. Okay, so as we go through this, we're going to just do this in a very simplified way. But there's a lot more that goes into each one of these steps that we're going to go over as the year progresses. Okay, so the first time through we went through here, we ended up with a bunch of diagnoses in our differential that we couldn't trash. We didn't feel comfortable enough to treat, so we are going to need to test further. So now we move up here to the history and physical side, right? Let's do that. So now we ask the patient what was going on, right? And so it's a 42-year-old guy. He says he has high blood pressure and he smokes, and he's here with 2 days of chest pain. It felt like someone was sitting on the middle of his chest. He gets tired walking upstairs. Coffee also makes his chest hurt. He's not been coughing, have any fever, and he also says that nobody stabbed him. Now, you asked him because that was in your differential. So we got to organize that information. And this is where we'll start using medical terminology to kind of condense everything together. So the first thing you have to do is characterize the chief complaint. What is the complaint that the patient had, which was chest pain? So it was acute, meaning it's been going on for a short time. Acute onset, it started suddenly. Exertional, meaning it's worse with exertion, right? He gets tired walking upstairs. Substernal, meaning it's under the sternum, it's in the middle of the chest, and it's been going on for 2 days. Okay, and then we'll also talk about some risk factors he has here, right? Cardiac risk factors, his age maybe, his high blood pressure, he's a smoker. The fact that it worsens with caffeine might make you think, okay, well, that's something that heartburn tends to do. He doesn't have a cough and he doesn't have a fever, right? So he's afebrile, no cough, right? And you bunch those together because you think, well, that's some things that I would think of with pneumonia, and there was no trauma, right? So now we go back to our differential diagnosis and we say, is there anything else we need to add here? So what else can we think of? Well, I thought maybe that people get out of breath with asthma. So maybe it's also could possibly be asthma. So now we're going to test our hypotheses again, right? We have the same scale here. Heart attack, uncertain, right? we don't have enough information to say that it is this or that it isn't this. So we need to continue further. We're going to test it. Pneumonia, you know what? We do have some information here that he doesn't have any fever and he doesn't have any cough. So it's unlikely. But is it unlikely enough that I'm willing to not consider it anymore? Let's say we're still worried about it. We want to get some more information. Okay. Heartburn. We're still uncertain because you know why? It did get worse with caffeine, and that's something that happens with heartburn, right? Stab wound, very unlikely because he said nobody stabbed him. So you kind of would know, right, if someone stabbed you. So it's probably not a stab wound. And so we're going to trash that one. And asthma, we're uncertain. We need more information. So now we've come through here and we've acquired some new data from the history. We've organized it, all right? And we looked at our differential diagnosis and actually added a new diagnosis there, which was asthma. And we tested them against the evidence that we had. And one of them we could trash, right? We could say that I don't think it's a stab wound because nobody stabbed him. But the rest of it we were still uncertain with. So we need to collect more information. So we're going to split this one in two. And now we're going to do the physical next. Okay, so here's his physical exam. His heart, these are his vital signs, or vitals for short. His heart rate is 90 beats per minute, which is normal. His blood pressure is 120/70, which is normal. His respiratory rate is 12 breaths per minute, which is normal. And his temperature is also normal at 98.6 degrees. He looks well. His neck is normal. His heart, he's got two heart sounds, you know, S1 and S2 is what we call them, and no other extra sounds. His lungs are clear on both sides. His abdomen is soft and his extremities are not swollen. Okay, now we need to interpret this information here, right? So we know that all of this means he's got normal vital signs. All of, over here, he's got clear lungs. His heart sounds are normal. His exam is basically unremarkable. So anything else that we would want to add to our hypotheses here? We didn't really get any new information here that makes me want to add anything here. So let's leave it at this, and now let's test these diagnoses against the evidence that we have. All right, so heart attack, again, still uncertain. We don't have any new evidence to say anything has changed, so we still need to test that one. Pneumonia, it's still unlikely. We didn't hear any crackles in the lungs with the pneumonia, so maybe that's some evidence that makes it a little bit lower, but maybe we're just too afraid to miss pneumonia, so we're going to still keep it on there. Heartburn, uncertain. Again, nothing here said that it was or wasn't heartburn. But asthma, maybe, you know what? We didn't hear wheezing. There was no wheezing. And so we know that with asthma, typically you'll hear wheezing. So at this point we say, you know what? I don't want to call it asthma. I'm going to remove that. I feel like it's very unlikely. I'm going to remove it from my differential. Now, we've gone through this one more time, right? We acquired new data. This is the physical exam data. And when we organize that information into, which is relevant to our differential, we didn't add any new hypotheses, but we did test our hypotheses against the evidence that we had, and we were able to trash asthma. But the rest of it, we still need to test, so we're going to get some diagnostic testing now. All right, so now we're going to acquire results of tests. So we get for heart attack, let's get an EKG. That is a heart tracing. For pneumonia, let's get a chest x-ray. And for heartburn, there's no real test that we can do here, but we can say if everything else is normal, we're going to try antacids and see if that works. Now, one thing you'll notice here is that the testing is based on the differential diagnosis, right? So you order things that help you make the decision. You have to pick things for a reason. And so let's take a look at these. Okay, so you get your EKG here, and don't worry that you have no idea what this means. You will. Probably by the end of this year, you're going to know a lot of what this means. But I'm going to tell you this. This over here is abnormal. This over here is abnormal. You can see how it goes up. And then there's all this space underneath here, right? All that space underneath here. Normally it looks kind of like this, where there's no space there. So you can see this morphology is present here, here, and here. And it's kind of doing the opposite here, whereas it was raised up over here, this line, it's pushed down, it's depressed over here. So this is consistent. We call this over here ST elevations. And these are what we call the inferior leads or bottom leads. It looks at the bottom of the heart. So this is consistent with a heart attack at the bottom of the heart. Okay? And then we also get a chest x-ray. And again, we're going to go over how to read these at some point. But this one is pretty normal. So you can see the heart over here. These are the lungs. This is the right lung. and this is the left lung. And for a pneumonia, you would see like a big fuzzy looking thing here. It looks like a cotton ball or something. We call that an infiltrate, and we don't see that here. And so this is a normal chest x-ray. So now let's interpret and organize again. For our EKG, we had those ST elevations consistent with a heart attack at the bottom part of the heart, the inferior part of the heart, right? And our chest x-ray we read as normal. So we interpreted the data that we acquired. Now we need to take a look at our hypotheses again. Is there anything we want to add to this? You know, this is pretty consistent with a heart attack, but there are other things that could give you ST elevations. We're not going to look at that now. This is a very simplified version. So let's add nothing to it, all right? So now let's test our hypotheses again. Heart attack, it's very likely, right? Because this is, we said it's consistent with a heart attack at the bottom of the heart. And remember his story, he got out of breath and he had the chest pain. So those things were also consistent with it. So we have a lot of evidence now for heart attack. We have some evidence now against pneumonia. Remember, he had no fever, he had no cough, he had no crackles in his lung, and he had a normal chest x-ray. All of those things you would see with when someone doesn't have pneumonia. You'd look for those things in people who do have pneumonia, and this person didn't have it. And heartburn, we're also going to say unlikely because we have another good reason why he's having the chest pain. So we're going to trash these now. So now we're left with one diagnosis right here, right? And so the next thing we need to do is treatment. And so you take this patient to the cath lab and you unclog that heart artery. And so we went through this entire process now, from acquiring the initial data, organizing it, making and testing our hypotheses. And if any diagnoses we needed to test further, we did. We gathered historical data and physical data and went through those 4 steps, and got diagnostic testing and went through those 4 steps. And remember, if for some reason you have diagnoses left here, you might have to go back and get more diagnostic testing or more history and physical. So hopefully you were able to see how that process of 4 steps being repeated over and over again, acquiring information, interpreting that information, making hypotheses or a differential diagnosis, and then testing that differential or testing your hypotheses until you arrive at a diagnosis works. Okay, great. Thank you. Goodbye.